I'm chairing the next session. But before I do, a couple of quick things to plug, if I may. The Nuffield participates in the Hartness Scholarships with the Commonwealth Fund. Robin Osborne, I don't know if I can't see. Robin, are you here? I can't see her. She's around. Yeah. This is a great opportunity for sort of mid-career people to go and do a piece of research on health policy delivery with a leading US health service researcher. It's a great mid-career opportunity for an academic or for a manager or a medic. There's a number of ex-Hartness people around. James Mountford, Emma Stanton are here. I think there may be others. If you are, make yourself known. Anyone else? Oh, there's Geraint Lewis, of course, yeah. Oh, and excellent. So, and Ruth, yeah, good. So do think about this as an opportunity for providing development for people. It's a lot of work for them. It's quite a big commitment for them and their organisation, but something that we're very pleased to be associated with. So let me encourage you to pick out one of the leaflets, find and talk to Robin Osborne if you have the opportunity to do so. She'll be very happy to talk to you about that. I can confidently say with her not in the room, but I'm sure she will. The second thing we just wanted to tell you about was a new initiative, which again I can take glory for from other people's work, which is the development of a panel of 100 healthcare leaders, which we're going to use to help us think about the policy run-up to the 2015 general election, so that we get a good cross-section of views and be able to sort of ensure that the analysis that we do is grounded in the reality of frontline experience. So if you're interested in that, again, talk to Daniel Reynolds or one of the who's comms director, or one of the other Nuffield staff. Let us know if you're interested in that. We want to keep the numbers relatively limited, and obviously it needs to be a reasonable cross section. So there's an extent to which we'll have to balance that against demand. The next session is about who's driving strategic change in the NHS. One of the things that's very striking when you talk to Andrew Lansley is that he had a very strong view about strategy, and in particular strategic health authorities. So he had this kind of sort of this regional strategic health authority chief executive sat in a hollowed-out volcano, plotting the closure of hospitals, and generally was up to no good. And it was very much embedded in a view he had that actually planning wasn't really very necessary, that the individual decisions made by patients and their GPs would shape the system. And that underlies quite a lot of the original thinking in the architecture that he was designing. And some work that I've been doing with Chris Ham in London, looking at this question of who is the system leader, who provides system leadership when you need to make big decisions, really kind of confirmed that there was an issue. This is a gestalt. You don't need to read the boxes, you just need to say, how does that work? Where do I start? So lots of different actors, all with different perspectives, all with a different view about how change is managed, quite often with a different view about what the objectives were, and no particularly well-established rules of behaviour, of engagement, of keeping people to agreements, and making sure that there's some forward progress. So the purpose of this session, which I've been asked to facilitate, is more interactive. We're going to involve you in helping us think about three questions, which is there really a problem with system leadership? And if so, is that an issue? Is it really a problem? If it is, how are people dealing with it? And the third thing is, what are the consequences of that in terms of what would we perhaps like to say about this issue to the two politicians who follow this session? Jeremy Hunt and Andy Burnham. So that's, and it's an opportunity also, I think the organisers of the conference were very keen to actually do a bit of, get you talking to each other as well, because the morning's been quite full on, so there's a bit more of an opportunity for you to share some experiences of what's going on. So to sort of set us off, we've got Mike Deegan from Central Manchester, who's also Nuffield trustee. He's just going to give his perspective on how that rather interesting map translates into real experience in Manchester. Mike.
Thanks, Nigel. Good afternoon, everyone. As Nigel said, I'll just try and paint a picture for what the current situation looks like in Greater Manchester. And hopefully it will become clear, as Nigel's diagram demonstrated, there's an awful lot of people on the pitch. As that guy from Genesis this morning said, there's not one individual in charge, so that means we've got to work really hard around alignment. And also, thirdly, the further you get away from the actual point of care in a locality, the more difficult it is to create that level of alignment and drive the change forward. Okay, across Greater Manchester, we're a tightly packed conurbation, population between 3 and 4 million. We have 13 different hospitals of sorts, 12 different newly formed clinical commissioning groups, 10 established local authorities, 3 mental health trusts. So quite a lot of even just standard NHS bodies on the pitch, let alone other organisations. When we start looking at how we drive change forward across Greater Manchester, I think when you focus within a locality, for example, Salford, Central Manchester, where more often than not you may have one local authority, one clinical commissioning group, one acute trust. I think there's some really innovative work in terms of how we develop more joined up packages of care that are genuinely centred around the patient and their carer. I think that's probably because we've got a clear common purpose in those patches. When we move to the next level, and then we look for change across a conurbation about that size, that's where I think some of the real tensions and difficulties start to get drawn out. And really, just to give an insight into, just to share a programme in Greater Manchester, which we locally call the Healthier Together programme. And part of that is looking at a reconfiguration of hospital services across Greater Manchester. And it's been formally sponsored by all the clinical commissioning groups, the specialist commissioners, and it's got active involvement of every hospital provider in that overall programme of work. And that's really starting to identify some of the tensions that Nigel started to talk about earlier. So how we're trying to move that forward, some again, real progress and a platform to move forward. So the 12 CCGs, having governance terms, come together. They've created a committee in common, so they're now statutorily able to make reconfiguration decisions that bind them all together. All our local authorities have come together under the Association of Greater Manchester Authorities and signed up to a potential decision-making basis. And all the providers come together under a reference group that's chaired by Ruth Carnell, and we've all been actively involved in the process. And we've even reached the stage where we've shared all our adherence to basic clinical standards, for example, around general surgery. And we've now got a common picture across all the hospitals in Greater Manchester of the extent to which we adhere to existing standards. We've also shared all our outcome data, so we know the variation, say, in mortality from emergency admissions. We've also shared all our financial plans. So at one level, we've got a really good basis to move forward. But the reality is we're not quite into the real game yet. And when we move to the stage of saying, hold on, how do we have fewer major 24/7 hospital sites and a larger number of hospitals that aren't DGHs but are local hospitals with really care managed across those organisations, not within the institution? As you would imagine, we're starting to get into some real difficult ground at the moment. So CCGs are having to balance their responsibility to their local communities and the prospect of moving some local services elsewhere. NHS England are also on the pitch. They have a local area team, and it's really interesting to see how their relationship is moving forward with individual CCGs. Across all the hospitals, the majority of us are foundation trusts, and the reality is we've all spent the best part of a decade focusing more on competition than collaboration as a way forward. And again, most people who work in foundation trusts see their accountability back to the institution, not to the overall system. So that's highlighting some real difficulties in getting all hospitals to sign up to what looks like some sensible change. As well as those core NHS stakeholders, as you would all expect, Monitor, the Foundation Trust regulator, is active in this regard, and there are several organisations either technically in failure in Greater Manchester or under second stage investigation by Monitor. The Trust Development Authority are also on the pitch. They're looking at how the 1 or 2 hospitals that aren't FTs can become FTs. There's also very recently been launched reviews of non-sustainable local healthcare systems that both Monitor and the TDA are involved in. When we talk about this change in Manchester, I have to go back to our Health and Wellbeing Board and report through to elected members on the local authority. So as you can see, we're accumulating all the people on the pitch that we need to get aligned on this. With the last set of reforms that Nigel described, we've now also got all our clinical reference groups, our operational delivery networks, clinical senates, all real potential drivers for change, but all need aligning. So I guess, Nigel, just in introduction, we're at the stage in Greater Manchester where we recognise many organisations on the pitch. The key will be how on earth we can develop a way to just coalesce all our interest. So we're no longer just looking after our patch that we may be technically accountable for, and how we can sign up to broader change across the conurbation. One final comment, if I may, Nigel, because often when we have this discussion in the NHS, people start to talk about the role of the intermediate tier, which of course was, seen away in the last set of reforms. And I do think it's a really interesting level of discussion, because when we look at the intermediate tier, which by and large covered a population of about 4 to 5 million, there were some areas, and I feel quite fortunate of having been in this position in the Northwest, where we had a SHA that tried to create a really permissive enabling framework and really helped organisations come up with strategically astute outcomes. But clearly other parts of the NHS seem to operate in a different way, and the intermediate tier, which could undertake a critical planning role, was a bit more focused on core performance management and not strategic oversight. So hopefully, Nigel, that just gives a local illustration of the amount of players on the pitch and how all this starts to come together or not.
Mike, you had one other observation about the experience from the Euro Summit about scale. Do you know just...
Yeah, really interesting. At the Nuffield Trust Euro Summit earlier this year, quite a lot of colleagues from different countries, different organisations were talking about how they started to develop effective strategic planning mechanisms. And I spent about the first day of that summit thinking about how we would create effective strategic planning structures in the NHS, thinking about the 50 million population. But when you spoke to the individuals, bar one exception, every other European country talked about units of about 4 or 5 million in terms of strategic planning. And when we talked about, doing it on a size of a country the size of England, they were quite taken aback that we'd even think about it. Was it in northern Spain?
Is it not? Yeah, I think it was. But that's probably 2.5 million. It's Catalonia. Yeah, right. Okay, good. So there's a diagnosis. What we want to put to you, I suppose, is 2 things really to start with, and we're going to get you to do a little conversation on your tables. Grown, but you are. They were my instructions. You've got to follow them. Do we agree with that? Is that? And if we do, is it an issue? And if it is, has it been dealt with? Have you got examples and ideas that are being talked about locally that start to do that? And I think we could do that for about 10 minutes. And we'll not do death by feedback. We'll just get some headlines back from you. Some of you on quite small tables, you might want to go and join. I don't know if you three want to go and... Anyway, you self-organise. Those... What was that, sorry? Yeah, I'm doing some strategic planning already. Some reconfiguration of that table. Do you recognise that description? If you do, is it an issue? If it is, how are you dealing with it? Lots of conversation there. Is it a problem? Yes? Anyone think no? Yes and no. Yes, thanks, Nick. Do you want to... Right, you get to elaborate. Very good. Nick Black.
Okay, Nick Black, London School of Hygiene. Yeah, it's a problem in terms of one key part of the health system, the hospital sector, which does require, we felt, some sort of higher level centralist thing. So, you know, the oft-quoted stroke in London, which we're all getting rather bored with. Somebody come up with another example. But before lunch, some of us here sat through 3 absolutely inspirational talks on integrated care in 3 different parts of the country. They have done that despite the jungle and the lack of joined-up organisations. So maybe it doesn't really matter at a local level.
Okay. Other views on this, and before we get on to solutions as they're emerging, I'll choose somebody. Do you feel lucky? Yeah, Andy. I don't know if I can get a microphone to you.
We think that the incentives are in the wrong place. Financial incentives are incentivising more activity to happen.
So we got the wrong incentive design. Yeah.
We think that health and wellbeing boards and clinical commissioning groups have got this important role in planning, but they're emerging organisations which, capacity and capability are at a very early stage in development.
Okay. But health and wellbeing boards being proposed, as we may hear earlier, as a major strategic decision-making bit of the system. And did anyone talk about that as a solution? Should we go and talk about solutions? Anyone got any solutions that are developing locally? Help me out here, folks. You must have some. Here we are. David.
Yeah, so I'm not sure. So David Stout, I'm Managing Director of Central Eastern CSU. So we weren't, I'm not sure, solving your problem. We're answering the question who's in charge of major change, I suppose. And when push came to shove, our conclusion was it's the special administrator. So if all else has failed, if we've been unable to reach agreement at local level and the system is in meltdown, then we do have a system in place, and it is a special administration system that then makes recommendations to the Secretary of State. So that's how the system is designed right now.
Yeah,
whether that's good
I mean, to
in the
use an
solution.
analogy, it's rather like saying that, the best way of dealing with diabetes is vascular surgery.
I don't think we were recommending this system.
Not recommending it. Okay.
We're just observing.
You're observing how it is. Sure. Excellent. Good. I mean, I need to work on my metaphors. They're really not very good. Okay. Any other observations, Stephen? Yeah. We'll just get the microphone to you so that the people who are watching this can hear. I've just realised I failed earlier.
Absolutely nothing wrong in talking about the London stroke change, even if it is the only one that we have to talk about. We were hearing that possibly today that wouldn't now be possible. It was hard enough then, and now might not be possible. 2 things we heard around the table. One was having a rigorous standards-based approach to these changes, so that then individual providers were, as it were, asked to match those standards rather than argue for their particular geography. And the second was that individual commissioners in a patch might give up some of their legitimacy to share that with others, so that there was an acceptance that there might be even majority voting amongst the commissioners in a patch, and so some pooled sovereignty of some sort.
Okay, thank you very much. Would you just propel the microphone towards Jeremy here? That would be... don't know what the... oh, there's one here. It's okay. Yeah, you hang on to that one. That might be risky.
We had a bit of a conversation about whether it was possible to respond to the challenge from the podium about people feeling accountable to the system rather than to their individual organisations. and I posited the thought that a system is quite a difficult thing to feel accountable to because it's too vague, but the patient is potentially something that people can feel accountable to. So if you have a common set of metrics and understanding about how good care is and what patients think about it, then you potentially start to mobilise people around a common purpose, which is the quality of care. That requires something about metrics. And
So
about,
it sounds similar to the
it's
point
not
about
unlike
standards,
Stephen's
yeah?
point. And then we had a conversation about, well, but then you still need to have difficult conversations with your communities about the changes you're going to make. And the default mode is still very much in, we're going to tell people what's going to happen because we don't want to have a difficult conversation, rather than let's make friends before we make decisions.
And then we just exhort everyone else to be brave, which seems to be the standard model. Politicians should be braver so they can do what we want. Never been convinced by that one, personally. Any other solutions? Could I just come back on this standards one? To what extent are the standards that we're currently operating simply artefacts of the way that Royal Colleges choose to want their members to work? I noticed Terence has gone home, you see. I just thought I'd... yeah, good.
So, Norman Williams, President of the Royal College of Surgery.
Excellent.
I can assure you that, that the data we collect and interpret is extremely valuable and helpful, and in fact has driven reconfiguration to some extent already. So you take the level 1 trauma centres, which is actually, and when you do that and you decide to have X number of trauma centres around the country in the strategic places, it drives change because you have to have a certain concentration of specialists around those centres. So there you're getting the reconfiguration. It's happened with vascular surgery. It's happening as I speak around gastroesophageal cancer surgery, and it will continue to happen because of the fact is that the benefits of centralisation, particularly in my area, show the evidence is just you can't get away from it, and that convinces patients.
The evidence certainly in your area is very good. I was thinking more about the job planning rules on how many people you actually need to run a rota in, say, obstetrics, rather than the evidence in vascular and trauma is really good. But anyway, I've just been provocative. You've answered the question. Yeah, it worked. That was the objective. I don't know if anyone wants to come back. Mike, yeah. So.
Well, a couple of points. One a bit off the wall. I'll come to last. But one of the things was that around the Greater Manchester changes, because the chief executives, and this is kind of repaying Mike's compliment in a sense around how we were able to work as an SHA at the time, was actually the chief execs had agreed a process, and they used Frank Burns rather than Ruth at the time around challenging them to reach agreement in advance of any formal process. So when it started to hit the fan in terms of decisions, the quality of the people in the room and a bit of process with some neutrality effectively went an awful long way to resolving things in advance of any of those difficulties that you get between providers. But the slightly more off-the-wall suggestion, and it wasn't really a recommendation rather than observation, was effectively that the more there is an appeal system up the line, i.e. the less incentive there is for local reconciliation, because you can carry on holding out until such time as you arrive at that point. And I think it is worth thinking about the benefits as well as the costs of having quite a lot of appeal processes in terms of arriving at some local agreements. But that was largely about the professional conversation and did nothing really to address some of the issues about the connection to the public about support for change, which still remains, I think, the bigger issue, really, in terms of where is the authoritative voice that convinces them of the need for change.
So you've got collective agreement as one of the mechanisms of this. Handling defection always seems to be one of the big challenges. It's always quite easy for people to go along with processes and then at some point to walk away. Mike, any observations on what you've been hearing?
No, I mean, it's all sensible stuff, Nigel. I think one of the comments earlier that if you're managing change within a locality where you've got a tight bunch of players, I think you can develop that common purpose. I think it's when we get into a broader footprint. So, and it's a good example around some of the hospital reconfiguration agenda. I think that's where a lot of these tensions play out. I would support several of the comments strongly that I really do think the way into that is through clinical standards, because that starts to strip away some of the organisational politics and arguments. But I think even when you go through that step, your final challenge, Nigel, how do you deal with a maverick organisation that may just be saying, no, we're not prepared to sign up to this? And I suspect we're not yet well versed enough in how some of the competition changes will play out to be able to work out what would be an effective ground to take on that.
Good. Any final comments before we close down? Let's do that then and say thank you very much. We're now going to hand over to Nick Timmins for one of the main events of the afternoon. Nick. Thank you, Mike. Yeah. We're done.